Hi, my name is Emily Speer, and I'm a surgeon at National Jewish Hospital and St. Joseph Hospital in Denver, Colorado. I'd like to thank SAGES for the opportunity to talk today about postpartum reflux. I have no disclosures. Briefly, I'll discuss an overview of postpartum reflux, the data we have so far, the clinical relevance of that data, namely how it applies to real-life patient outcomes, the nuances and technique that may affect postpartum GERD, and future considerations. So when reviewing the data for post-POEM versus post-Heller reflux, you'll see that there have been a number of systematic reviews and meta-analyses published. A couple done recently are outlined here and are really enlightening. The first, done by Demora and colleagues, entitled POEM or Surgical Myotomy for the Treatment of Achalasia, a systematic review and meta-analysis, concluded that, quote, there was no difference in postoperative GERD between lap Heller myotomy and POEM, and there was decreased length of hospital stay for POEM. There was also a nicely done study by Patty and colleagues similarly titled Laparoscopic Heller Myotomy versus POEM for Achalasia, a systematic review and meta-analysis that showed, quote, patients undergoing POEM were more likely to develop GERD, and on average, length of hospital stay was 1.03 days longer than POEM. So the data are not super clear. Overall, the incidence of post-POEM GERD is estimated to be anywhere between 17% all the way up to 57%. And the reasons for these varying data are probably multifactorial, but the most important factors are differences in POEM technique, as well as a heterogeneous method of assessing GERD in these studies. In this nice meta-analysis by Patty's group that I previously mentioned, you can see that most studies define GERD as GERD symptoms, which we know are totally unreliable in achalasia patients. Only about half of those studies looked at endoscopic findings of esophagitis, and less than a quarter got any objective pH studies at all. So we know that GERD symptoms are completely unreliable in achalasia patients, and this has been demonstrated in multiple studies and was nicely laid out in this study by Jones and Perry and colleagues that showed that the results of pH studies after POEM did not correlate with the severity of reflux symptoms whatsoever. So studies looking at reflux rates after POEM without any pH or endoscopic data kind of clouds the pictures. They may or may not have GERD, true GERD, so it's important to get objective testing via endoscopy or pH. And along the lines of clinical relevance of post-POEM GERD data, it appears that most GERD that we see after POEM is mild, like LA grade A or B. Most is asymptomatic, well controlled with PPIs, and don't require subsequent surgery. In this 2019 New England Journal of Medicine paper, it was a prospective, multi-center, randomized controlled trial with 221 patients with achalasia who were randomly assigned to POEM versus lap Heller with DOR. They found that at 3 months, 57% of patients in POEM versus only 20% in Heller myotomy had reflux esophagitis on endoscopy. And at 24 months, 44% of POEM versus 29% of Heller patients had esophagitis on endoscopy. So this sounds really significant. However, when you break it down, high grade, LA grade C or D esophagitis was actually similar. At 3 months, it was 6% in POEM versus 3% at Heller. And in 2 years, it was 5% with POEM versus 7% with Heller. Furthermore, pH data showed similar objective GERD. At 3 months, it was 44% in POEM versus 33% in lap Heller. And at 2 years, it was completely the same, 30% with POEM versus 30% with Heller. So with the objective data showing that most esophagitis is mild, pH data is similar, are studies exaggerating how problematic post-POEM reflux really is? Our own SAGES Society seems to think so. In these guidelines for the use of POEM for the treatment of achalasia, a panel of SAGES experts stated that the only undesirable effect, reflux esophagitis on EGD, was considered to be a small effect, as the biggest difference between procedures was seen for grade A esophagitis and not for the more clinically relevant grades B through D esophagitis. As I previously mentioned, along the lines of clinical relevance, most true post-POEM GERD tends to be asymptomatic with nearly 100% symptom control on PPI and almost no need for subsequent anti-reflux surgery. In these two papers, this was outlined nicely. So Dunes, Swanstrom, and Revis looked at 100 consecutive patients who underwent POEM. They found abnormal pH testing in 38.2% of patients, but only 50% were symptomatic, and all symptoms were controlled with PPI. Inouye and his group did a study of 70 patients who underwent POEM. They found endoscopically visible GERD in 32.9% of patients, but only 11.4% were symptomatic, all controlled with PPI. And symptoms and endoscopic features of GERD actually decreased with time at 4-year follow-up. So we know that post-POEM reflux is an issue, but it's probably an issue that's being overemphasized in the literature. There are multiple nuances in POEM technique that are currently being studied to see what impact they have on postoperative GERD. We know that it's probably not a great idea to do a POEM on a patient with hiatal hernia. One of the things that's postulated as well that could decrease the risk of postoperative GERD is the ability of POEM to preserve a nice intact frontoesophageal ligament. So we kind of know those things, but further areas being studied are the importance of preserving oblique and longitudinal muscle fibers and the ideal length of gastric myotomy. So as I just mentioned, there's some thought that preserving longitudinal esophageal fibers may actually help decrease post-POEM reflux. It's still unknown. And there's some variance in technique with some institutions performing full thickness myotomy versus others taking only the circular fibers, which kind of complicates data collection. There's also some thought that the gastric oblique fibers may be important for reducing post-POEM reflux. And the 3 main myotomy techniques that are being compared in the literature right now are anterior myotomy, which inherently preserves the oblique muscle fibers, posterior myotomy with making a concerted effort to preserve the oblique fibers, and then versus posterior myotomy without preservation of oblique fibers. The length of gastric myotomy is also increasingly thought to affect post-POEM reflux rates. With lap-Heller myotomy, we know that the gastric myotomy greater than 3 centimeters is important for preventing persistent dysphagia, but there's some data suggesting that the same might not actually be true for POEM. Inouye's group published a study of 100 patients with a median follow-up of 3 years, and they found that gastric myotomy length greater than 2.5 centimeters actually tended to increase moderate esophagitis, but did not improve dysphagia resolution. And they recommended keeping myotomy length between 2 to 2.5 centimeters. And additionally, they recommended preserving the oblique fibers as there was a tendency towards increased post-POEM reflux when these were sacrificed. They also recommended a double scope technique to control the length of the myotomy as well as to ensure a complete myotomy. So for future considerations, parsing out the importance of oblique gastric and longitudinal esophageal fibers is important, as is determining the ideal gastric myotomy length using things like EndoFlip or the double scope technique, et cetera. These are all going to be very important in the future. While the need for surgical intervention to deal with post-POEM GERD remains very low, it's important to keep looking at endoscopic anti-reflux options such as POEM plus fundoplication, which Inouye and his group described, in which they make a full thickness myotomy after their POEM and use the endoscope to go in and grab the anterior fundus and create a door fundoplication essentially. And most importantly, assimilating more objective post-POEM GERD pH testing data is going to be very important to fully understand its true impact. So in summary, POEM has a place in treating achalasia. Like all other therapies, it has its pros and cons. When you look at things like pneumatic dilation, that also has a lower GERD rate, but other factors play into it not being a great treatment option for everyone. As Ezra pointed out, type of achalasia, POEM being superior for type 3 achalasia is an important factor, as well as things like surgical candidacy, ability to tolerate pneumoperitoneum. All these things are important factors to take into account when choosing to pursue Heller versus POEM. So POEM does have a place. GERD is not a problem exclusive to POEM. Randomized controlled trials show 20% of patients with lap-Heller develop reflux esophagitis, and anti-reflux medications are used in 39 to 69% of patients after Heller, and some of these patients develop Barrett's esophagus, et cetera. The AGA, ISD, and SAGES all recommend POEM as a viable alternative to lap-Heller myotomy, and thus POEM is here to stay. Thank you.